Hello everyone, myself Dr. Parth Goswami and today I am going to teach you about oral cavity squamous cell carcinoma. I have included the tumor burden and the pattern of invasion as well in this particular lecture. So this particular topic comes under the competency number PA 24.1 according to the NMC Indian curriculum, in which a student need to describe etiology, pathogenesis, pathology and the clinical feature of oral cancer. Now, among all the oral cancer, the important one is the oral squamous cell carcinoma. The long answer question could be asked in the form of write down the etiopathogenesis and morphology of oral squamous cell carcinoma, which is a 10-mark question. In your university theory exam, you can be asked short answer question in the form of write down the morphology and its variant of oral squamous cell carcinoma. Sometime one-liner, 1 or 2 mark question can be asked in the form of write down the 4 etiology of SCC, write down the 4 morphological feature of SCC like that way. So that is the competency. Now, first of all, you need to understand what is the classification of oral cancers as per the World Health Organization classification. So the oral cancer can be divided into various ways. The first category is epithelial tumor, which include oral epithelial lesion with a mild, moderate and severe dysplasia, which is a precancerous lesion, or we can say carcinoma intraepithelial neoplasia, right? It's a intraepithelial neoplasia. Then it could be in the form of proliferative verrucous leukoplakia. Third example is oral squamous cell carcinoma, right, which we are going to discuss in our today's lecture. Second category of oral cancer is a papilloma, in which papillary formation is present. It's a benign tumor. So it could be squamous cell papilloma, or it could be in the form of verruca vulgaris or condyloma acuminatum. These last two examples comes under the category of HPV infection, right? It's a human papilloma virus induced papilloma. All right. Now, third category is oral mucosal melanoma, right? Melanocytic tumor. Fourth category of oral cancers are salivary type of tumors like that of pleomorphic adenoma, mucoepidermoid carcinoma, adenoid cystic carcinoma, polymorphous low-grade adenocarcinoma or the myoepithelioma. The fifth category is soft tissue or the neural tumor. Soft tissue tumor examples are rhabdomyoma, which is a muscle forming tumor, right? Granular cell tumor, then lymphangioma. Then neural tumor example include neurofibroma, schwannoma, and Kaposi sarcoma also could occur in a oral cavity in the buccal mucosa, right? Particularly in the HIV patient. The sixth category is odontogenic epithelial tumor, that is the ameloblastoma. And the seventh category is lymphoid tumor, that is non-Hodgkin lymphoma, B cell lymphoma, right? So this is the seven category of oral cancer classification, among which we are going to discuss about oral squamous cell carcinoma in the detail. So in India, the oral cavity cancers are the most common malignant tumor. In India, it is very common, and among all that, dear student, you won't believe the 95% oral cavity cancers are squamous cell carcinoma. Alright, so first of all, let's begin with etiology. How oral squamous cell carcinoma occurs? What is the etiological factor? So the first etiological factor is tobacco smoking in the form of cigarette, bidi, cigar or pipe smoking. Sometimes reverse smoking also practice in some area. So, tobacco smoking is the most important etiological factor for the development of SCC. It is a tumor initiator as well as promoter. All right. The second etiological factor is tobacco chewing in the form of betel quid or pan. Uh, you know, it is practiced in the form of taking a wrapped betel leaf. Certain ingredients are present like that of areca nuts, slack lime, and the tobacco that will wrapped in a betel leaf and that is consumed. So that is the tobacco chewing, right? So that is the second etiological factor. Third etiological factor for the development of SCC is a radiation exposure, right? All right. Now, very interestingly, the fourth etiological factor for the development of squamous cell carcinoma is alcohol. It is having the synergistic additive effect along with tobacco. So, if a patient is tobacco smoker and drinking the alcohol as well, then the chances of development of squamous cell carcinoma is a 15 times more, right? So, alcohol is one of the very important etiological factor. Other etiological factor could be welding workers, wood stove exposure and asbestos exposure. All right. The eighth etiological factor is chronic irritation of our buccal mucosa. That could be by chronic infection or by the jack teeth. Chronic infection could be in the form of oral candidiasis, oral syphilis, like that of. Vitamin A deficiency and the malnutrition also put you at the risk for the development of SCC. And the main recently trending etiological factor for the squamous cell carcinoma development is a human papilloma virus infection, right? HPV 16 and 18 strain, particularly these are the high oncogenic risk type HPV, right? If you are infected with HPV 16 and 18, then chances of development of oral SCC is more, right? So HPV is a very important etiological factor for the development of SCC and particularly in the Western countries. All right. Oral syphilis, obviously, chronic infection puts you at the risk of development of SCC. Many SCC patients show a positivity with Epstein-Barr virus infection, so it is also one of the etiological factor. And interestingly, if you are taking the lace fruit and the lace vegetable, then you are at a more chance of development of SCC. That's why it's advisable to eat more fruits and vegetables. All right. Now, pathogenesis. Why squamous cell carcinoma develop? So, it could be because of P16 inactivation, it could be because of mutation of P53 gene. P53 gene is a tumor suppressor gene. So, if P53 gene is mutated, then, the damaged DNA will not get repaired, the mutated cell will not get removed, and the mutated cell will continuously getting proliferated. If you want to learn about in detail, then see my video on tumor suppressor gene, right? You will be able to better understand how P53 gene prevent the cancer formation, and that's why it is known by the name guardian of genome. All right. Amplification on and overexpression of cyclin D1 gene also responsible for the development of SCC. And obviously, HPV 16 and 18 showed positive relationship with the SCC. How HPV lead to cancer development? HPV gene is having a various viral oncoproteins, right? Particularly E6 and E7 proteins. They are responsible for the mutation in the P53 gene, inactivation of P53 gene, inactivation of RB gene. If you want to learn it in detail at how HPV lead to cancer formation, then I have already made the video on that in a microbial carcinogenesis, right? All right. So, HPV 16 and 18 detected in 50% of the tonsillar ring carcinoma, while in other oral cancer, it is only 10% positive, right? Less than 10%. So, if the patient develop tonsillar ring carcinoma, Wilder ring tonsillar carcinoma, then chances of HPV positivity is more, right? So, this is about the pathogenesis of SCC. Now, which are the site of cancer in the oral cavity? All right, and this P16 inactivation, how it lead to cancer formation. So it's related to cell cycle, right? The cell cycle regulation is lost. So that also I have explained in my proto-oncogene lecture. So you can check the playlist of neoplasia to detail learn about this each pathogenesis. All right. So which are the site of oral cavity cancer development? So the most common site is tongue and then lip. But in India, the common site is buccal mucosa, particularly retromoral triangle. That's why, because the Indian population is having habit of putting the tobacco underside the mucosa, right? Underside the buccal mucosa. The second site is tongue and then lip and the lower alveolus, right? Soft palate and gingiva can also be developed, can also be the site for oral cancer development. All right. Now, what is the gross morphology of oral squamous cell carcinoma? How grossly it look? So grossly, the squamous cell carcinoma in the buccal mucosa or in any area of the tongue, palate, it can present in a four way. One is ulcerative type, in which the patient develop ulcer. It is the most common presentation, right? The patient complaining of non-healing ulcer since long time, and which is indurated, right? Painful sometime, and with rolled out everted margin. Second form of presentation could be papillary or verrucous. It is a soft and wart-like growth. Third is nodular, and the fourth one is serous type, in which there is an infiltration into deeper tissue. Now you can easily correlate this each category in the schematic diagram given in the Hirschmohn book. See, This is the ulcerative type, means ulcer formation is present. Second one is papillary or verrucous type, in which there is a papillary or verrucous projection. You can see that there is a projection, verrucous projection. In nodular type, there is a formation of nodule, and in the serous type, the lesion is flat but deeply infiltrating into the deeper tissue. Alright. Now, after understanding the gross morphology, let's discuss if you take the biopsy, then how it look in a microscope. If you prepared a slide, then what is the microscopic histopathological appearance? You know, morphology is in the form of gross morphology or microscopic histopathology. So we have discussed about the gross morphology. Now let's see which are the microscopic features of SCC. So obviously, the patient can develop a squamous pulp. The malignant squamous cell will do the keratinization, and if squamous keratin pulps are present, then it is suggestive of well differentiated squamous cell carcinoma in which the prognosis is good. Intercellular breach is observed in the SCC. Third category is disorganized growth. Dyskeratosis is also seen, which is a premature keratinization. It's seen in the corneal epithelium. There is a loss of basal polarity, which is a feature of SCC. In the SCC, as it is a cancer, there will be high NC ratio. There is a prominent eosinophilic nucleoli, and there will be abnormal mitosis, like that of flower-shaped mitosis, right? Abnormal mitosis is present. Necrosis could also be seen. This high NC ratio, prominent nucleoli, abnormal mitosis, pleomorphism, that type of features are suggestive of anaplasia, which is seen in any cancer. The main characteristic hallmark of cancer is anaplasia and the metastasis. So anaplasia means loss of differentiation, and the features of anaplasia are high NC ratio, prominent nucleoli, mitosis, like that of variation in size and shape. So that can be observed in all cancers. And sometime in the squamous cell carcinoma, a lymphovascular invasion, that means penetration into the blood vessel, or perineural invasion means the squamous cell present surrounding the nerves can be present, and it is suggestive of poor prognosis, right? Now you might have questioned which is the most important criteria for the diagnosis of SCC. So remember, dear student, the SCC can be diagnosed only if underlying stromal invasion is present. Stroma means blood vessel, fibrous tissue, underlying dermis. In the skin, it is known by the name dermis. So right, if below epithelium, the stroma is present. If the stromal invasion is present, then and then the case can be labeled as squamous cell carcinoma. All right. So this is the histopathology of squamous cell carcinoma microscopic feature. You can see that these are the cancer cells, right? And it is doing the keratinization. They are infiltrating the stroma. That's why it is a SCC. All right, see, the invasive tumor cells can be seen in the stroma. See, this whole stroma is invaded by a cancer cell. These small are the cancer cells, right? And you can see a prominent nucleoli in each cancer cell. See, the nucleoli is very prominent, very dark, right? And the whole stroma is invaded by the cancer cells. All right. Now, before full-fledged of cancer development, there could be verrucous hyperplasia, there could be keratosis, right? With mild, moderate, or severe dysplasia. Dysplasia means pleomorphism, high NC ratio, like that of anaplastic feature, right? But polarity is not lost and the stromal invasion is not present, then case cannot be labeled as SCC, but it should be labeled as keratosis or squamoproliferation with mild, moderate, or severe dysplasia, right? All right. Now let's understand the prognostic factor related to the oral squamous cell carcinoma. So, which are the prognostic factors? So, the common prognostic factor is location of tumor. If the tumor is located in a lower lip, then prognosis is good, right? Grade and stage of the tumor is a most important prognostic factor. Suppose if the patient is well differentiated, if the keratin pearls are present, then the prognosis is very good. 5-year survival rate is very good. But if the tumor is of moderate to poorly differentiated, then prognosis is very poor. And the stage of tumor, particularly TNM staging, that is given by American Joint Cancer Committee, right? If AJCC staging is high grade, if TNM staging is of T3 or 4, then the prognosis is poor. So the grade and stage of tumor is a very important prognostic factor. Tumor size, obviously if the size is more, the prognosis could be poor. Depth of invasion, if the depth of tumor invasion is more than 5 millimeter or more than 1 centimeter, then prognosis is very poor. The more the depth of invasion, poor is the prognosis. If the tumor is induced by HPV, human papilloma virus, then the survival rate is high as compared to HPV negative tumors. If the P60 gene is expressed, then the prognosis is favorable, right? Survival rate is more if P16 is positive, which is a cell cycle regulator. All right. Now, this is the recent update as far as the SCC is concerned. What is tumor burden? Tumor burden is a very important prognostic factor. So the tumor burden suggests the epithelial mesenchymal transition, means the epithelial cell acquire the property like that of mesenchymal cell, right? It is suggestive of EMT. And tumor burden means the presence of single tumor cell or a small cluster of cell in the stroma. Small cluster means less than 5 cell group in a stroma. So if in the stroma, obviously the squamous cell carcinoma means the stromal invasion by cancer cell is present. So if this invasion is of single cell or it is made up of cell group of less than 5 cell, then it is known by the name tumor burden. And if these tumor bud are more than 5 in number, right? If there is a more than 5 tumor bud in the stroma, then it indicate a poor prognosis. But if the tumor bud is less than 5 in number, then the prognosis is good. So kindly, if you are a pathologist, then report the tumor bud in the report because it is related to the prognosis. More than 5 invasive tumor bud is suggestive of poor prognosis, and the tumor bud means less than 5 cell group. All right. Pattern of invasion, that is also important prognostic parameter, right? So what is the pattern of invasion? So the pattern of invasion means invasive pattern could be of 5 types. There are 5 grade, right? The grade 1 means verrucous like. The grade 1 means only broad pushing invasive front is present. I mean the single broad front, the broad front, invasive front invading the stroma, no individual single cell. Grade 2 means broad pushing invasive front with a separate tumor island, right? The big invasive front is present along with separate tumor island. Grade 3 means invasive tumor island is present but each island contain more than 15 cells, right? In each invasive island of tumor cell, if the number is greater than 15 cells in a island, then it is grade 3. Until now the prognosis is good, but if grade 4 or 5 is present, then prognosis is poor. Grade 4 means invasive island of tumor cell which contain less than 15 cell per island, including a single cell invasion as well, right? So that is grade 4. If in the stroma single cell invasion is present or less than 15 cell per island tumor cell is invading, then it is grade 4, which is suggestive of poor prognosis. Grade 5 still related to very poor prognosis. It means, this criteria is present, but tumor satellite is present with greater than 1 millimeter distance from the primary tumor, right? So that is grade 5. So these are the pattern of invasion. All right. These 4 and 5 grade pattern of invasion is of very high risk type, which is suggestive of poor prognosis, right? All right. So see, in this particular example of SCC which received in our department, you can see that there are more than 5 invasive tumor bud. See, the tumor bud means less than 5 cell group. So obviously these cells are the single and less than 5 cell groups. You can see that whole stroma is invaded by tumor buds, right? And the number of tumor bud is many. Here, 25 to 50 tumor buds are present. If it is more than 5, then it's related to poor prognosis. And the pattern of invasion is of grade 5, 4 to 5, right? Means single cell invasion is present. See, the single cell invasion is present. And in the each island, you can see that the invasive tumor cell is less than 15 in number, right? The each island contain less than 15 cell. All right. See, this is the perineural invasion. This is the nerve. And surrounding the nerve, there is a presence of squamous cell, malignant squamous cell, so which is suggestive of poor prognosis. All right. Now, what is the immunohistochemistry finding of SCC? IHC can confirm any morphological diagnosis. So, morphological diagnosis can be confirmed by IHC. In the SCC, usually it is not needed, but you can put the IHC for the confirmation in case of a doubt. So SCC will show a CK5-6, cytokeratin 5 and 6 positivity. SCC also positive for CK8 and CK19. SCC could be positive for P53 and CK13. CK13 in case of an metastasis. So these are the positive marker of SCC as far as the IHC is concerned, among which most important one is CK5-6. And CK20 is negative in a squamous cell carcinoma. Alright. Now we have talked about the traditional conventional squamous cell carcinoma. But sometimes morphologically the variants are existing, right? Means the morphological presentation is not conventional. There are different variants available, which can be presented sometime in your practice. So which are the morphological variants of SCC from the conventional type? So the first variant is verrucous carcinoma. It is also known by the name Ackermann tumor, which is related to a very good prognosis. And in the verrucous carcinoma, the pattern of invasion is of grade 1. There is a voluminous broad red ridges which invade deeper into the stroma. Here you can see that the squamous cell invasive front, invasive red ridges into the stroma. Here the stroma is infiltrated by a broad red ridges, broad bulldozing, pushing red ridges. The bulldozing, pushing type of invasive fronts are seen. Understand, these red ridges are very broad and they are deeply infiltrating into the stroma. The single cell or the tumor island is not present, right? So that is the verrucous carcinoma. It's very well differentiated and no distance metastasis has been observed. And that's why the prognosis is very good. Radiotherapy is not indicated in verrucous carcinoma because it can change the behavior of the tumor, right? Alright. Second variant is pseudoglandular adenoid SCC. It means the true gland formation is not present. Because of acantholysis, it mimic the appearance like that of gland formation. That's why it is pseudoglandular adenoid SCC. See, this is the pseudoglandular adenoid SCC. These are the glands, but it's a mimic. It is not a true gland, right? If the true gland is present, along with squamous cell carcinoma, if the gland forming cancer is present, adenocarcinoma is also present, then it is known by the name adenosquamous carcinoma, which is a third variant, right? See, this is the adenosquamous carcinoma in which the malignant cell forming the gland as well as squamous cell are present. The fourth one is papillary SCC, which is associated with very good prognosis. The name itself suggests, here the papillary formation is present. See, this is the papillary SCC, and it is associated with human papilloma virus infection. All right. The fifth category is basaloid SCC. It is a very aggressive variant. The name itself suggests, here the SCC will present with palisading basaloid cell. See, in this diagram, you can see that this basaloid cell is having palisading appearance, means they are parallel, nuclei are arranged parallel to each other, that is palisading, right? So the palisading arrangement of basaloid cell is present and the basement membrane is very thick. So that is the basaloid SCC, right? If you do the IHC, then high molecular weight keratin and the P63 is positive. HPV16 positive in most of the cases. Alright. Small cell carcinoma is it's a very aggressive variant of SCC. The cells are small and the prognosis is poor. The seventh category of SCC, seventh variant is sarcomatoid carcinoma. So why the name sarcomatoid carcinoma is given? Because the cancer cell will be spindle cell. So obviously it looks like an pleomorphic sarcoma or fibrosarcoma. You can easily get confused. See, this is the fibrosarcoma or pleomorphic sarcoma like picture, right? These are the spindle cells. See, these all are the spindle cells, malignant spindle cell, right? Along with malignant histiocytic like feature, right? See, this is the pleomorphic sarcoma like picture. Fibrosarcoma, sometimes it can look like fibrosarcoma. So this is the sarcoma like picture, right? No one can say it's a SCC, but here the focus of SCC is present. So in such confusing case, you can do the IHC. It might help in a differentiating. If it is SCC, then it will show positivity for CK56. All right. The eighth variant is lymphoepithelioma like cancer. Lymphoepithelioma cancer commonly seen in the nasopharynx. So morphology is very similar. We will discuss lymphoepithelioma cancer in the detail in our nasopharynx cancer chapter, right? All right. So this is my reference for the today's lecture. I have prepared this lecture from the Rosian Ackerman Surgical Histopathology book, which is a very good book for surgical histopathology. Then I have taken some portion from the Robbins and Hersmont textbook of pathology. So that's all about the squamous cell carcinoma. Hope it will make your fundamental clear about the squamous cell carcinoma. This particular topic is very important for the undergraduate as well as postgraduate student, and I have included many important aspects which can be useful for reporting histopathologists as well. So that's all about the squamous cell carcinoma, and I will be right back with a new video. Till then, take care and bye bye. Thank you very much.